Okay, so what we're going to talk about today is the classic maxillary-molar immediate implant extraction case. This case is a 74-year-old male with a failing root canal. Patient desired immediate replacement if at all possible, and tooth number 2 is already missing. His past medical history was benign, and he's a non-smoker. So here's our pre-operative picture. If you look at the mouth, you can see the typical draining fistula from his healthy mesiobuccal root, where you can see bone breakdown around the tip of that, which is a very common finding. Once the crown was off, you could see that there was also a crack in the tooth, which might have been part of his problem as well. So the typical immediate maxillary molar implant case with removal of a root canal tooth, the tooth usually comes out in pieces. On rare occasions, you get it out in one piece. Oftentimes there's a crack. So what you're aiming for is to keep the bone or preserve the bone and have that as a landmark drill placement. So what you do is you start with this little spike drill right at the confluence of the interradicular bone as a target. And then once you place the mark with that, you use a round burr followed by a 2-millimeter twist drill. And this, you can see, you establish your point of reference, and then you go down to the depth measured off of your Banner X-ray. So it's sequential drilling of a depth. This is the same depth each time with a 3.25, 4, 5, and 6-millimeter drill, where you're taking out bone at the tip of the drill, and then able to place a trial sizer down to that depth that you prefer. And this is what it looks like once you've prepared your um, site. Next, you take your implant, which you can see is a titanium screw, with or without a polished collar, it doesn't matter. And ultimately, your goal is to get placement in bone as deeply as possible. And then on the drill, the pressure is measured in Newton centimeters. You start at 20 and go to the depth before it locks up. Then you go to 35, and then it goes a little deeper, and then you get up to 50 Newton centimeters, and it stops up. At that point, you hand the implant to a depth of approximately 3 millimeters below the gingival margin. Following that, an encode healing abutment is placed, and that establishes a boundary for soft tissue to grow to and to seal the wound with ultimate growth up to the surface of the implant. It's sutured shut, and the sutures are left in place for approximately 2 weeks. This is your postoperative x-ray, and you can see that the tip of the implant goes just through the sinus floor. And the value of that is that cortical bone on the surface of the sinus floor adds a certain degree of locking of your implant that you wouldn't otherwise get in alveolar bone. Now I'll show you a couple more cases. This is a Larry case where it's going to be the same tooth, but you can see this is the end result, and this is what it looks like, again with the tip of the implant through the sinus floor.